pathologies in the spine can be divided into developmental, traumatic, infectious, neoplastic, and inflammatory and other musculoskeletal pathologies. We'll be covering trauma and infection today. Regarding the imaging evaluation, conventional radiographs is the initial diagnostic screening. The AP and lateral views are done. Nuclear medicine, technetium MDP SPECT can detect spondylosis, spondylolysis, stress fractures, and osteoid osteoma. It may not identify the other pathologies like bone tumors, soft tissue tumors, and soft tissue infections. CT is the modality of choice for characterizing fractures, monitoring healing, detecting progression. It can be used for preoperative evaluation of spinal trauma and scoliosis. However, it cannot detect pathologies like early stress fractures and intraspinal lesions. MRI is the modality of choice for diagnosing bone marrow, intraspinal or paraspinal pathology. However, the disadvantage is relatively high cost and the need to sedate younger children. Coming to pediatric spine in children and adolescents is anatomically different from that of the adult. There is increased cartilage bone ratio, the presence of secondary ossification centers, and soft tissue hyperelasticity. Vertebral bodies in the pediatric spine are also partly cartilaginous and the intervertebral disc spaces appear larger. Vertebral apophyses develop at the superior and inferior surfaces of the vertebral bodies. They appear by 5 years of age and fuse by 18 to 20 years. The traumas, the cervical spine injuries in the children usually occur in the upper cervical region, that is from occiput to C2-3 level. The cervical fractures are more common in younger children. Approximately 72% of the spinal injuries in children under 8 years of age occur in the cervical spine. The causes are fall, birth injury, non-accidental trauma, or other underlying conditions like Down's, Marquez, etc. There are several differences between the pediatric and adult spine in the cervical region. The fulcrum of motion in the cervical spine of children is at the C2-3 level. In the adult, it is at the C5-6 level. The hypermobility of the cervical spine in children is due to the ligamentous laxity, the shallow and horizontal facet joints, underdeveloped spinous processes, physiologic anterior wedging of vertebral bodies. All these contribute to shear forces acting on the C1-2 region. There is also incomplete ossification of the odontoid process, relatively large head and weak neck muscles, which predispose to the instability of the cervical spine in the pediatric population. There are certain anatomic variants in children. One is pseudo-subluxation, which is a normal physiologic displacement that can be seen at C2-3 and to a lesser extent at the C3-4 level. This anterior displacement, which is up to 4 millimeters, is normal. This occurs only in flexion and should not occur in extension radiographs. This normal mobility is differentiated from a true injury by the Swiss-Chucks line. This line is drawn from the anterior aspects of the C1 to the C3 spinous processes, and it should be within 2 millimeters of the anterior aspect of the C2 spinous process. The absence of lordosis is another variant which can be seen in children up to 16 years of age when the neck is in neutral position. This is an example of pseudo-subluxation of C2 over the C3 vertebral body, and this is the line which is drawn from the C1 to the C3 spinous process at the anterior aspect, and this line should be within 2 millimeters of the anterior aspect of the C2 spinous process. The other variants are anterior wedging, which up to 3 millimeters of the vertebral bodies should not be confused with compression fracture. This can be marked at the C3 level with deformity of the vertebral body ossification center at its anterosuperior corner, and this is thought to occur secondary to the hypermobility